childhood cancer. Dr. Nwoku is the Deputy Director, National Coordinator, National Cancer Control and Nuclear Medicine Program of the Federal Ministry of Health and Social Welfare of Nigeria. Thank you very much.
Thank you so much, Dr. Joseph Federayo, and good evening, everyone else. I'm sorry I wasn't supposed to be the first, but because I'm in the office and I'm asked to attend under meeting, I have to seek your consent to present first. So I want to thank you for inviting me. Can you hear me, please? I hope I'm from there. Can you hear me, everyone?
Yes, we can hear you, Doctor.
Oh, all right. Okay. Thank you.
Yeah.
All right. So I'll quickly run through the few slides. So I'll quickly run through the slide I have, and if there are questions, in case I'm not able to stay to the end, I will request the moderator to allow me to take 1 or 2 questions before I exit at 4:30. Thank you so much for this opportunity to speak. I was asked to talk about bridging gaps in pediatric oncology, the role of Global Initiative of Childhood Cancer. And I just want to start by sharing a brief about Nigeria and then what we are doing with regards to GICC, which is being implemented in collaboration with St. Jude's Childhood Cancer and the World Health Organization and other partners, including, of course, Dorcas Foundation. Currently, Nigeria is, as we all know, is the most populous Black nation with our current estimated population at close to 250 million. And if you look at the bar chart on the right, you can see that about 21.4% of our population are children, those who are below the age of 14. So that means whatever we are doing in terms of childhood cancer, we are looking at about 21% of the population of Nigeria. So, and this is the only age group that, if properly taken care of, can grow up to be among the productive age and probably those who are going to reach the elderly. So if we're not able to do enough, then the current challenges of infectious diseases coupled with cancer may further affect the population that we are having in the country. And if you look at the graph on the right, by 2050, the country is expected to reach up to 359 million. And this will also increase the number of people who are likely to be affected by cancer. So that means it's something that must be closely looked at by everyone. Now, if you look at our population and this current slide, talking about the Nigerian health system, this is just, I don't know how many of us here are Nigerians, but just to remind us that our health system in Nigeria is in what we call a concurrent legislative list. So that means both the federal government and the state government have equal legislative powers to make laws as far as health is concerned. However, the National Health Act of 2014 gave the Federal Ministry of Health the sole authority to develop policies for health, including cancers. Okay, so that means the Federal Ministry of Health is the only one that can develop policies that should be adopted by the rest of the tiers of government, the state and the local governments, for implementation. And of course, those policies developed are also expected to be implemented by the state, by the private sector facilities. So my position in the Federal Ministry of Health is the one in charge of cancer control, policy development and implementation. And so childhood cancer becomes one of those that we have placed as a top priority. Now, when we make our policies are meant to be implemented across all the 3 tiers of government that also own the different levels of healthcare, including the tertiary, the secondary, the primary healthcare, and the public health and the private healthcare centers. So these also have their linkages. The state government also owning both tertiary and the secondary levels of care, and the primary healthcare under the domain of the local government levels. Of course, there are still other health facilities at different ward levels and community levels. So all of these are influenced by the policies that we make. And of course, at every point of this, there are some level of childhood cancer care service, whether at the point of diagnosis or treatment or even palliative care, okay, are going to be provided at different levels. So the next slide, please, looks at our health system also. Just to remind us that maternal mortality, childhood mortality is still a serious concern, with 35 out of 1,000 live births in Nigeria. So that means with cancer also afflicting the children, then this also adds to the cost of childhood mortality in the country. And of course, this also put our expected lifespan to also be at a very low level. Unfortunately, if we look at the total health expenditure, over 73% of the health expenditure come from, 71.6% comes from out of pocket. So this also affects how parents are able to cater to their children who have cancers. So this is very catastrophic in nature. And that is what the GICC is also coming to help us to bridge. Because if over 71% of the health expenditure for cancer care in Nigeria is going to be borne by the families of the children, then you can imagine how many of them can or will be able to initiate treatment, remain on treatment, and probably complete their care. These are some of the things that we hope to address through the GICC. Now, I'm sure we all are aware that the cancer burden has continued to increase, and then even it's currently the second leading cause of death worldwide, with the low to middle income countries bearing the most burden of cancer mortality. So this is what is currently happening, and then if all effort is not made to stem this, then we are into some sort of a pandemic. Okay, and then if we look at this, yeah, the Global Cancer Observatory, this talks more of the adults with over 127,000 new cases, and then 79, almost 80,000 deaths happening in Nigeria. But what is significant to us with this information is that 7.2% of this data due to childhood cancer. So, which is also, though may appear small compared to the adult cancers, but of course, because of the vulnerability of the children, then this 7.2% is very significant for us as a country. And this is also compounded by limited capacity for early detection, as many childhood cancers are not necessarily preventable. Early detection is a way that can assist in improved treatment outcomes. So, but with our limited capacity for early detection, then it becomes a serious challenge. So this makes close to over 70% of the cases being diagnosed at advanced stages where treatment outcomes are very, very poor. So this looks at comprehensively information about the stages where cancers are diagnosed in Nigeria. And I don't know if you can see the slide very well, as many of them present stage 3 of almost 60%. And this has not changed over a very long period of time. So between 2010 to 2014, the one in black, and then 2015 to 2018, the one in green are essentially the same. So a lot of efforts need to be made to increase awareness and improve our detection capacity to be able to reverse these very advanced stages of cancer diagnosis in Nigeria. So with all of this, government is not sleeping, so we've taken steps to develop different policies and programs from the right right from the inception of NCCP, which was established in 2006, we have developed several policies, programs, and activities ranging from the National Cancer Control Plan 2007 to 2020 to 2013, 2018 to 2022, 2022 to 2027, and of course the latest one that has just been approved, 2026 to 2030. And then other policy documents like the chemotherapy policy, palliative care policies, and recently nuclear medicine policy. But I must confess that the previous editions of all these plans and policies did not squarely address childhood cancers. But we have been able to, with the support from all our partners and TWG members, including Dr. Adedayo of Dorcas Foundation, Dr. Kinshete, and many other TWG members, we've been able to develop a new national cancer control plan, which has been approved now and is going to be launched on the 4th of February 2026. So that is the National Cancer Control Plan 2020-2030. So this has different pillars, and then all of these pillars specifically have sections that address childhood cancers. And then this new plan is properly aligned with the Global Initiative for Childhood Cancer, because when Nigeria joined the GICC in 2024, we needed to take steps to ensure that the GICC initiative is well integrated in the International Cancer Control Plan. Now, the National Cancer Control Plan is a document that has to be implemented by all our agencies. And like I said, the Federal Ministry of Health is the sole authority in Nigeria to develop policies and programs. Okay, so we are hoping that this will be implemented by all our agencies, including all the research institutes, NIMA, NIPRI, NICAT, and all the other agencies like MPSCDA, the National Health Insurance Authority, and of course, all the 84 federal government tertiary health institutions and all the states tertiary institutions and secondary levels of care. And of course, we're also hoping that all the private healthcare players will also key into this. Now, the aim of this alignment is to achieve at least 60% of survival for childhood cancer globally by 2030. And that is why this plan is also going to be reviewed at the end term. Of course, we're going to have quarterly review, but of course, the end term review will be in 2030, and to ensure that we've been able to attain 60% survival for childhood cancers in Nigeria. So the plan is also hoping to leverage on the Cure All framework to increase access to quality childhood cancer care in Nigeria. So this cannot be done alone by government. So like I said, we partner with all our institutions, the parastatals, the research institutes, and other regulatory agencies to ensure that relevant equipment, manpower, training, and all the other regulatory frameworks are put in place to ensure adequate implementation. And of course, working with development partners and collaborators, including the Dorcas Foundation, WHO, IAEA, ACS, CHI, World Children's Clinic, and other institutions. Now, what is the implementation goals for these plans is to establish clear screening and referral pathways for those that can be screened, and of course, address financial barriers to care, and expanding diagnostic and treatment services, and to establish robust cancer treatment facilities. So this will be able to provide comprehensive cancer care across the country and improve access to all the treatment for different cancers in Nigeria. So these are the goals, and we're hoping that this will be attained before the end of 2030. Now we have strategies to implement the GICC. So one is to improve access to quality, cost-effective, and equitable diagnostic and treatment services for cancer care. So currently, we are working with different partners to improve access to chemotherapy, including biologics and diagnostics testing to ensure prompt diagnosis. And then we're also collaborating with different medical and professional associations to increase awareness. Recently, we have been able to develop childhood cancer awareness jingles. WHO developed and shared with us, and we have been able to translate into three different languages. So we hope to continue to disseminate this to create awareness so that people don't think that any child who is having fever or crying or pain somewhere, there is either malaria or typhoid, which is what some of the time what people believe. That many of them may actually be incubating one cancer or the other, and that has to be taken seriously. So we're hoping to improve healthcare provider knowledge on standard of care for effective treatment and quality of cancer care. And of course, we have adopted the NCCN Harmonized Guideline as a treatment guideline for Nigeria. So we continue to update and be part of that guideline to ensure that we provide our healthcare providers with the requisite tool to be able to implement the GICC and our NCCP. So strategy 2 is to achieve best possible quality of life for patients and families facing life-threatening illnesses. So this is well aligned with the hospital and palliative care policy, which have been developed. So it's not just for adults. Even children also need some of support. Of course, the children and their parents need the psychosocial and pain management support right from the point of diagnosis until survivorship. And then, of course, if unfortunately those who may be bereaved, even at bereavement, they also need to have all necessary support. So the other strategy is to increase cancer awareness, like I talked about. We have developed a jingle to actualize this. Then, of course, to conduct and integrate programs that provide high-quality cancer data for dissemination, research, and planning. So there's nothing we can do if we do not plan. And that the planning will also be influenced by the outcomes of different scientific evidence that come from our institutions. And then, of course, those evidence also be disseminated, and this will help us to constantly review what we are doing, kind of monitoring and evaluation, and of course, learning lessons to further engage and ensure that we actualize the goal of the NCCP. So already we have a childhood cancer population-based registry in Lagos and Abuja. We're hoping to also probably have more, to fund them and be able to use them to be able to generate data that will be used for subsequent national planning. So, and then ultimately to ensure availability of drugs, consumables, and functional equipment for cancer care in Nigeria. Talking about childhood cancers right now. So these are some of the strategies we want to adopt that are well aligned with ensuring that 60% of childhood cancer care are provided within the country. So in conclusion, the full implementation of our National Cancer Control Plan 2026 to 2030 with strict alignment with GICC will make the desired impact in childhood cancer care in Nigeria. Thank you so much for listening.
Thank you very, very much, Dr. Oche. That was amazing. I confess that even I didn't realize how much work is being done. You know, we tend to be aware of only what we are personally doing and personally involved in. So, I mean, just congratulations on all the work that you're doing. As you know, you have the full support of all the teams that are working in pediatric cancer in Nigeria. I don't see any questions in the chat at this time, but if you do have any questions, please feel welcome to share them in the chat, and then we will bring them up. At this time, I want to call up our next speaker, who will be taking the next session. Just give me 1 minute to share. So let's look at her beautiful face. How do I go to expression? Okay, so this is somebody that I personally known for a number of years who has been very instrumental in a lot of the work that we have done. She's a health system strengthening research, doctoral student, expert, subject matter expert. She has the experience, she has the expertise. I personally find her to be a teacher, to be somebody who you can use as a sounding board, who deeply understands, health systems and understands what the connection between outcomes and systems and processes, and one needs to go into it in order to bring it out. She's currently at the Institute of Health Policy Management at the University of Toronto. Welcome, Ms. Paulette Becker. Thank you very much for talking with us this afternoon.
Thank you, Dr. Joseph. That was such a kind introduction, and thanks. I appreciate it. Good day, everyone. from wherever you're joining, but I see most people are from Nigeria, so good afternoon. And I miss the warm weather, and looking forward to being able to be part of um, the Lagos PSYOP Africa to get a feel of the warm weather again. But again, thank you, everyone. I think I really appreciate the fact that I'm going after Dr. Uche. And I want to echo Dr. Joseph to say congratulations, Dr. Uche, on a national cancer control plan, an updated national cancer control plan, and that it includes, a lot of details for children, because that is indeed the goal. I think, the irony of it is that across the world, sometimes children are thought of after adults in a number of instances, and this is sort of the case in cancer. But we will fix that with all of our efforts to make sure that they're not forgotten anymore. But more critically, I'm going to take this opportunity to bring attention to advancing childhood cancers and adolescents and young adults cancers, or at least they're why we need to focus on them and how ICAIA plays a role in all of this. And so children, for the most part, some people don't even know that children have cancer. But fortunately, that's changing. And in the instance where children have cancer and they survive, they make it into adolescents, or they become an adolescent or a young adult. And we shouldn't forget them. And in fact, you know, with with the with the status of things right now, it almost seems like where you're born determines whether you're even going to make it into that adolescent or young adults age. And it's really exciting to see that the WHO, St. Jude's, Sick Kids, the Dorcas Cancer Foundation, and several players, CHI, ACS, are all working together in different ways to bring attention to different things and different components of childhood cancer. And then hopefully we don't get into that place where we widen our adolescent and young adult gap. It's an existing gap all over the world. But I think the goal is, as we think about the children, we'll focus on them as well so that we don't widen the gap in our instance. And so, fortunately, like I said, we have commitment from the WHO and the St. Jude's Global Initiative working together to achieve the Global Initiative for Childhood Cancers, which is, again, to support all countries across the globe, whether high income or low income, but especially low income countries where we see survival rates below 30%, as opposed to high income countries where it's 80 and higher. We definitely want to see a situation where across all of implementation, starting from the policy all the way to initiatives at the facility level to research, that we're really thinking about children and adolescents and young adults. And it's always really interesting when you see the age that defines each of these groups. And children pretty clearly 0 to 14, and adolescents and young adults span all the way from 15 to 39. And one may say, why is that why is that gap there? And it's because of the peculiarities of surviving as a child and the challenges that come out of it. And so, fortunately, we have a number of things going on. We have the St. Jude's Global Platform for Access to Childhood Cancer Medicines. We have the Collaborating Center at WHO, where you have really the strong commitment and using the cure-all framework to develop and to support countries to ensure that you have strengthening centers of excellence and care networks with a sufficient and competent workforce. So again, this is how do we ensure that from obviously at the teaching hospitals, similar to some of the work that the Dorcas Cancer Foundation is doing with PEDROC, but also even before children get there, how do we support healthcare workers at the lower levels of care, as Dr. Uche mentioned, not to disregard the next fever that the same child has shown up with as um, malaria again, and to ask and to suspect and say, it might be time to refer you to a specialist to confirm what exactly you're dealing with. And I'm actually quite excited and happy to be working with the Dorcas Cancer Foundation, who have actually implemented and are consistently looking for how to sustain the Look Again campaign, which was implemented in 2019, and looking to strengthen it. And so I'm excited to be working with them to identify how we can do that, and potentially work with Dr. Uche and several partners to explore how to strengthen that implementation in the states where TDCF has actually implemented it, and beyond those states. So again, we have that. So how do we ensure that centers of excellence have the right number, have sufficient and competent workforce? And it's a case of also how do we strengthen our pediatric oncologists, and also encourage other people. I remember while leading some of our work in Nigeria, and interacting with residents, and one resident said, I avoided it because I just don't want to go to a place where it seems there's no hope. And so changing that narrative will certainly get a number more people to get interested in pediatric oncology. The other thing is facilitating universal healthcare coverage with health benefits and organizational models that will ensure quality services for all children. So again, sustaining that where a child is diagnosed should not define whether they are going to make it or not. So how can we support our governments? How can we advocate? Again, these pillars don't just stand on their own. They're enablers that support these pillars, and I'll talk a little bit about them in a few minutes. But how do we work with, the National Health Insurance Agency to identify ways to do this? Some countries in the African region are figuring this out, Kenya being one of them, that has identified mechanisms to cover cancer care for adults and children, and consistently reviewing how to make that stronger. So there are lots of opportunities, and these are some of the things where, that fortunately WHO and St. Jude's, through the Collaborating Center, are putting together, figuring out how to support countries to achieve this. The third pillar is, again, how do we ensure that when indeed a child makes it to a health facility, that treatment regimen is exactly what they need, considering our context. So we're not going to bury our heads in the sand and say we don't know that some things are not available, or that there are things, there are contextual differences, right? And sometimes we may not learn these contextual differences until we start to use this regimen. So like Dr. Uche mentioned, unfortunately, Nigeria has adopted an NCCN harmonized guidelines, and potentially and fortunately, there are, pediatric regimens there. And again, it's an evolving treatment guideline. I also know that St. Jude's and WHO have mechanisms to also support with additional treatment guidelines. So again, what do we need for our context? What do we need for our children? How do we make sure that when they are indeed treated, the right treatment is used? And then finally is evaluation, monitoring, and research. And this is potentially where I'm hoping to really sit. We have all these amazing evidence that's worked in high-income countries, working in low-middle-income countries in similar contexts as ours. How do we ensure that we're evaluating and making sure that what we're choosing to implement actually works for us within our context, right? And again, that's where all the different levers and enablers come in. So there's advocacy, there's leveraging financing, there's linking policies and governance, and that's again is where it's really exciting to hear that there's an updated National Cancer Control Plan, and it has maintained ensuring that the cure-all framework is part of the control plan, and that we're making taking steps. I think the next thing I'm just going to talk about is just collaboration. I know that the Dorcas Cancer Foundation has been excellent at that. I mean, I met Dr. Joseph while still working in, wearing my chai hat of the and leading the work that we did to improve access to cancer care. And they were very open-armed to collaborate, and that's what we will need to keep doing. There are several groups across the globe also within our context, and fortunately Dr. Joseph and team and are also working with the Sick Kids Center for Global Child Health and exploring mechanisms to strengthen capacity and to just learn what's happening on the ground and how can we strengthen this. Again, we really need to ask, what is our context? I think if there's one thing that I'm gaining more and more appreciation of, it's that, like, what is where are our children seen? What are the symptoms? What are the cancers that we see the most? How can we leverage what we already have at our tertiary facilities, but also at our secondary and primary care facilities? Again, it's not about making sure we adopt things, but also ensuring that we replicate them to our needs, but more critically, how do we sustain it? And it's partnership with government, it's partnership with other partners in the space, it is partnership with other partners globally, it's partnership with it's partnership and it's advocacy, right? It's these conversations that we're having and just making sure that things are moving in the right direction. And I think the role of ICAIA here is, how do we apply the voices and embed adolescents and young adults every single time we're having this conversation? Again, there's that gap, they were treated as a child and potentially got the best care, and now they're about to become an adolescent, or they have become an adolescent or a young adult, and we're not thinking about all of the other needs they have, so psychosocial needs, fertility, mental health needs, and even survivorship, because again, they got this outstanding treatment that dealt with the cancer, then had side effects and consequences on another part of their life, of their system. How do we make sure that we're thinking of these, catching them, and supporting those who are affected to improve this? And maybe I'm being a bit audacious, but I'm going to take advantage of this platform and just to advocate to everyone here, especially Dr. Uche, who is incredibly passionate and has been working very tirelessly to improve what the landscape looks like. And a couple of things is, first, again, congratulations that my first point, you've already talked about it, which is we have a new cancer control plan that has not left childhood cancers. And maybe before we launch it, we need to ask and interrogate whether we have in some way, shape, or form left adolescents and young adults. And if we have, can we make those changes before we launch it in February 2026? Or as there's usually a plan and there's an implementation framework. And maybe the question there is, maybe that's where we update that, right? And maybe it's not the plan. Maybe it's already at the place where it's sitting at the minister's desk to be signed and there's nothing we can do to it. But as we develop an implementation plan, can we also ask the question about where adolescents and young adults sit? And then again, how do we strengthen partnerships? How do we ensure that the right people at the table, that we are inviting the National Health Insurance Agency authority, we're inviting Primary Healthcare Board to these conversations. We're inviting the myriad of development partners that are beginning to see the value of addressing non-communicable diseases because, again, as Dr. Uche mentioned, most of them are not preventable, right? We don't have research that says you need to do this. And so it's really about early detection and providing them treatment and, again, care beyond that. And then how do we start to ask very honestly the financing questions? Who are we going to? Are we going to the Ministry of Health? I mean, to Minister of Health? Are we going to, the legislation to? I know that with the Cancer Health Fund, there was a conversation around expanding it to include childhood cancers. How do we move from that approval has been given to making it a reality? And it's also really fantastic that after many months of, working together and making a case for now how Nigeria needs to be part of the GICC, we're part of it. And so how do we then move to take advantage of the global medicines platform, right? It will be such a great opportunity, but from my understanding of all the other countries that have been part of it, there's a lot of groundwork that needs to happen. How do we do that? And then again, perhaps more selfishly, I'm going to also flag research. What are we doing to make sure we're doing implementation science research to say as we're implementing, we're learning and we're changing things. But also clinical trials in a number of countries, that's how children get prioritized in health financing to make sure that they're getting access to medicines that are valuable to them. And we can also learn from the challenges in those countries to begin to think about our opportunities. I mean, all the things that I'm listing are opportunities. I refuse to see barriers, but at the same time, we cannot ignore them. I refuse to dwell, I should say, on barriers, but at the same time, we cannot ignore them. And so the question is, how do we see these barriers? And instead of dwelling on, oh my goodness, this is really challenging and tough, and saying, how do we get on this as soon as we can to take advantage of the opportunities and make edits where necessary. And I think finally is that holistic approach. Again, it's fantastic to see that there is that sense of focus whenever there's a conversation around childhood cancers. We want to identify them early. We want to get them to treatments quickly. We also want to get them to, once they are done with treatment, how do we ensure that we're supporting them with everything they need beyond survivorship? And again, these are potentially future members of society who are contributing actively. And so, again, I think it's collaboration, advocacy, and ensuring that we have a critical and a consistent look at the way we're doing things, updating it, making changes, but again, being very honest about where we are, but not getting daunted that we can't move forward. But that's a little bit of what I'm adding today. And I'm just excited that these conversations are happening, and hopefully we can continue to move them forward. Thank you.
Thank you very much, Paulette. That was really engaging because, one of the things that we found working in Dorcas Foundation is that many times adolescents and young adults get lost in the conversation. So you talk about, childhood cancers, and we're thinking about really young children and thinking about Wilms tumors and retinoblastomas. And then you go from there to adult cancers and, talking about people who are already in adulthood. So, that age group between 15 to 24, where we're seeing nasopharyngeal cancers and colorectal cancers, the research there is, there's a massive research gap there. There is a significant gap in addressing their specific needs. And this is both clinical, but also emotional, psychological, policy-wise. There's no access programs that are dedicated to AYAs. There are NGOs who are concentrating on funding childhood cancer, and there are programs that are, addressing childhood cancer and then adult cancers. Nobody is thinking about adolescents and young adults, and they tend to fall through the cracks many times in terms of funding, in terms of policy directed at them, in terms of their care, emotional and psychological, in terms of reintegration into education, relationship, fertility. There's so many concerns they have that just don't get addressed on any kind of large scale. And I'm so grateful that now we're beginning, enough attention has come to pediatric cancer in general, that we can now begin to talk not just about childhood cancer, but then we can begin to dissect it to say, okay, there's young children, there's adolescents, there's young adults, and these are all different groups with specific problems that need attention, and I'm just really grateful for that. I think we do have a question that was directed at Dr. Uchi. Unfortunately, we're very low on time. I might have to ask Dr. Uchi to answer that in the chat, because we do have to call the next speaker, Dr. Ade Shaya Kinshete, who is an associate professor of hematology and oncology at the College of Medicine, University of Lagos, a consultant oncologist with the Lagos University Teaching Hospital, a board member of the Dorcas Cancer Foundation. Dr. Kinshete, good afternoon, sir, and thank you very much for joining us this afternoon.
Good afternoon, everyone, and thank you for having me. So I'll be talking about the emerging landscape of pediatric oncology in Nigeria. So next slide, please. So this just gives an overview of what I'll be talking about over the next 10 minutes. That pediatric oncology, a decade ago, we were not in the room, we were on the corridors. Now we have a seat at the table. And the overview of it is that we're not talking now about whether we can treat childhood cancers in Nigeria or not. Rather, we're looking at how can we modify and scale the system so that we have a quantum leap towards answering all the needs that the system needs to focus. And the critical thing for us is that if I look over the last decade, with where pediatric oncology has moved, I think that we're significantly on the right path. And in the next 10 years, we're going to talk about cure rates that would almost approximate what you would have in some parts of the West, even with our limited resourcing. And the critical things are that from a governance standpoint, the Federal Ministry of Health and Social Welfare has looked at the gaps in the system, and they created a body for research and treatment. So what that does is that once we can fix our research gaps with regards cancer in children from this part of the world, then it's easy for us to look at the therapeutic indices and the modes of treatment for our people. So that will give us some push. The other bit is that once you don't have data, then your conversation is not robust. So the government looked at the fact that we didn't have strong registries across the country catering to pediatric cancers. So the first population-based pediatric cancer registry was established in Lagos late 2023. And we've looked at the data sets over the past 2 years, as it were, and we're seeing a beautiful and a definite trend that we can leverage upon to plan. Now, we found out there were difficulties with that data set. And so we approached people who were experts in fixing this problem, the St. Jude Global Alliance. And so St. Jude is assisting us to incorporate our data set into their more robust framework so that the particular things that you need in pediatric cancer data registrations are met. And what that means is that we can now answer the right questions that you need asked about data sets in children. As a step further, St. Jude is now saying, look, you guys can't just sit down in Lagos and take all the data in Lagos and think that you can extrapolate this to the nation. So what the Nigerian Society of Pediatric Oncology is now doing, working with St. Jude, NICRAT, and the government, is that, look, let's look at how we can strengthen hospital-based pediatric oncology registration across the country. So as we speak now, we have 10 other institutions who are training registrars who are trying to standardize how data is retrieved and improve registration. And then finally, if you don't have money, you can't answer any question, anywhere in the landscape. For the first time, there's a budget line now, the National Childhood Cancer Health Fund. It's a paltry sum, but what it means is that we have a starting point to negotiate how we want the system to improve. So we can see that we're closing the ecosystem and we're ensuring that all the loopholes are met. And over the next 5 years, there will be a quantum leap as to what you will get across the different parts of this landscape. So next slide. So this is something we all know, the survival gap that we have. 30% approximately in LMICs, over 80% in high-income countries. So how do we bridge this gap? Those three things we talked about earlier would assist us in approximating this gap and improving outcomes for our children. Next, please. Now, this is what you will find as globally representing most of the cancers that you see commonly amongst children. And when we looked at our data set from the registry that we've had over 2 years, it followed the same trend. It dovetails with what WHO is doing through GICC. So we know that we're on the right track. Now, what we need to do is we have data, we're improving data set, we have some money, we're improving the landscape. Let's see how we can scale up and let's see where we are and what we need to do. Next. So the first thing that is something we need to fix. So we have a disconnect in our ecosystem now. Government is doing a lot with improving infrastructure. So you have between 2015 and now, several 3D linear accelerators scattered around the country. I mean, the juiciest of them is this cancer center in Lagos, where you have 3-linacs, brachytherapy, and you have all what you would need to make cancer care outcomes good for pediatric oncology. However, you have this infrastructure now scattered across different parts of the country. There's a plan by the government that in the next 2 years, we're going to have nuclear medicine capabilities in 6 other institutions in the country, where we'll be able to do PET-CT, PET-MRI, and finer things with regards to diagnosis and monitoring of treatment. However, the elephant in the room is that we're building this beautiful infrastructure. We don't have the manpower to run them. So that creates a problem for us. We have the beautiful infrastructure. We don't have the quantum to meet the needs that we have in terms of specialty and subspecialization. So we need to innovate. And part of that innovation has been what Dorcas Cancer has been doing in the landscape. Let's first improve virtual training. Second thing is let's improve scholarship to get people to subspecialize in pediatric oncology, in pediatric radiation oncology, in pediatric pathology. Once we do that, we would close down our workforce deficiency. The last thing we need to then do is to see how we can negotiate with government to include the private sector and improve remuneration across the people who are working in this subspecialty. Because if we don't do that, what will then happen is that we would have all this beautiful structure. We don't have the specialists and the subspecialists to man them, because what I wrote there as the brain drain, the Jackpot syndrome, the pull effect will always be there. I won't be working in a situation, in a system that pays me $600, when with that expertise, I can earn $3,000 in other parts of Africa. So we need to find how to leverage on the private sector to ensure that we improve remuneration in our space, sometimes outside government, to enhance our outcomes. Next slide, please. So I've talked about this earlier, but this is what we're looking at. We create a national research agenda. Dr. Joseph talked about the retinoblastoma agenda, but we've also created a pediatric childhood cancer research network. And what that is done, what that means is that we've modeled that after the Children Oncology Group in the United States and possibly the CCLG in the UK, where you have focused research groups across the country looking at different questions. So one of the first we are doing is that we're trying to look at any new genetic drivers in Black children with Wilms tumor. That is ongoing now. We're getting data and we're getting tissue samples to look at if there are new drivers for Wilms tumor amongst African children, especially Nigerian children, because we're looking at the clinical phenotypes we're seeing. We're seeing that literature says, hey, you give this, you expect this outcome. But it's not all the kids that we do that for that we get the same outcome. So is there a difference in that? So that's a research agenda. We're trying to create a research agenda for retinoblastoma, and we will do that across the common cancers and see if there is a phenotypic difference within the country. So research is one way of utilizing data to enhance therapy and improve outcomes. And NICRAT sits in that bucket. They get us the research funding, they drive the data for us, and most importantly, we are standardizing treatment. The unfortunate thing now is that you have several groups across the pediatric oncology landscape with different forms of protocols and treatment guidelines. We met with one of the leading groups and we told the director that it would be nice for us, the different groups that have standard protocols and guidelines, to come together and have one or two harmonized guidelines for pediatric oncology, especially in low to middle income countries. That will then help us to track how we treat patients and what the outcomes are. So what we are doing currently now is that in the Nigerian Society of Pediatric Oncology, we're trying to get people to adopt treatment guidelines that the nation has adopted. The federal ministry is a signatory to some harmonized guidelines. Let's start using them. Let the child in Lagos get the same treatment as the child in Abuja, as the child in Ekiti. Let's then see what were the ways in which you tweaked your protocol and what were the outcomes. Then we put it together in a pool, and then we statistically will look at it and then say, oh, when you did ABC, your outcomes were XYZ. When you did this, your outcomes were this. And so we can have better information on how to move forward. So gone are the days where somebody just sits down and just decides that, look, I'm going to give this child this. No, that therapy goes to a multidisciplinary board. That board looks at it. That board looks at what is available locally in terms of supportive care, in terms of expertise, and decides on what's best for them. So that's what NICRAT is trying to drive. That's what NISPO is doing. That's what Dorcas is assisting us to push across. And hopefully, as we do this across the landscape, we will improve. Next, please. So I've talked about the Cancer Health Fund. So Dr. Uche, who had the first presentation, talked about approximately 70% catastrophic expenditure by parents. We find that over 85% of the parents that access care for cancers for children in Nigeria pay out of pocket. That's not a sustainable strategy. Over the years, we've had to work with Dorcas, and Dorcas started with paying for care. It wasn't sustainable. Then they took a step back and they started analyzing in which areas do we plug our payments. We've seen that one of the critical and most expensive components of the treatment spectrum is radiotherapy. Radiotherapy is the most expensive part of our therapy. And that's what Dorcas is trying to do now for us, that, okay, you have a patient who comes in who needs to be treated for Wilms tumor. We will start sourcing funding for radiation because we have 6 to 8 weeks before we get to radiation. Most of these parents can't afford radiation. You find people, the average salary is about $70 a month. Radiation costs about $600 to $700. So there's no way they can meet that. So Dorcas has been doing that. So we need the private sector. Now, the government looked at our landscape and says, okay, you guys have been advocating for a cancer health fund. They gave us a cancer health fund this year. Unfortunately, it's about $30,000 to $40,000, but it's a starting point for us. And what we want to do now is, working with NICRAT, is to first improve private sector buying into this cancer health fund. Once we do that, we hope that the fund will grow. The other bit is that we want to ensure that the fund is channeled towards the most critical parts of care, so that once we start treatment, treatment goes through. We published a paper where we looked at what was the average cost of care for kids who are treated with leukemias, rhabdomyosarcomas, and co. And we found that the fraction with which we attain cure in this part of the world is 10 to 15% of what you will use in the West. So we don't need so much fund. We need to get the critical fund into the critical areas, and then we will improve our outcomes. Next slide. So global action, local impact. That's what this talk is about. First thing is, we've started our move to get on GICC. All of these things are parts of the subsets of the framework that pushes GICC. We're trying to ensure that we meet those subsets before we finally get onboarded to the program. The second thing is that we were finally this last year able to get St. Jude to look our way in this part of the world. And what that has done for us is that St. Jude has lots of years of planning landscape, improving access to care, enhancing outcomes, and generally improving the quality of care of children who are treated with cancers globally. They're working with the WHO to drive the GICC agenda, but we don't want to stop on that. We want to leverage all their end-to-end knowledge to ensure that the kids or the professionals or the landscape within our country benefits from their immense rich faculty. So we had a program January last year where we looked at our landscape, profiled some of our hospitals. A much larger part of that program will happen next year, where we want to onboard more hospitals into this profile initiative and then begin to enhance capacity across the different parts of the country. The other bit is that we want to formally engage civil society groups, Dorcas. So what we are trying to encourage is every hospital should have a not-for-profit that works with them specifically for pediatric cancer. We have achieved a lot in Lagos because we worked with Dorcas. We have some other agencies we work with, but Dorcas has helped to drive the narrative that now we're getting funding to try to improve research among residents, enhance interest amongst medical students. So we're trying to build further than just give care and help treatment. We're looking at the whole landscape, and that's what we hope that all the other institutions will begin to leverage upon and get partners to move what they're doing forward. Next slide, please. So, infrastructure. Part of GICC talks about centers of excellence. This is our hospital in Lagos. I mean, these are pediatric oncology ward. And then adults came in and borrowed some part of our building to use. What this does is that if you look at outcomes in dedicated pediatric oncology units or dedicated cancer units, outcomes would always be better than when you have a general hospital or a general ward and you are treating different patients. So that's the next push for us as a nation. We've tried it in some institutions, 2-3 institutions. Now we see that, look, there are better outcomes when we have everybody under one roof. Let's begin to scale this to other parts of the country. Let's begin to ensure that all the nurses, all the people that give care are in one location. The challenge we have is the challenge of the distance decay effect. You find that there are quite a number of issues that are plaguing the pediatric oncology referral network within the country. So you have huge distances between centers of excellence or pediatric oncology units and the referral centers. And most of them are clustered in the city centers. So what you then have is that you find that the continuum of care is broken and fragmented. We hope to be able to try and figure that out when we start doing scaling down and ensuring that we include community health extension workers and primary medical officers in our care continuum to try and bridge some of this gap. But hopefully we'll be able to bridge that and see how we can improve everyone and include everyone in it. Okay, next slide, please. So this is our vision. We want to get 60% survival target, just like what GICC is saying. We want to get data coverage. And hopefully as we do that and work with all our partners, we believe we'll be able to get there. Thank you very much for listening.
Thank you very much, Dr. Akishete. That was amazing. A very, excellent way of putting together all the work that's happening and summarizing it. And I like that you don't have a filter about certain things. You're very honest about the way things work. So we're coming to our last speaker for the day, and I think we're actually still quite good on time. So if you do have questions, put them in the chat, and hopefully our speakers will be around till the end to be able to answer those questions. I know we have one pending question for Dr. Ochi, and I'm really grateful that he's still with us. I hope that we'll be able to take that question at the end of the session. So next, I'm going to call our final speaker for the day. Let me just confirm that Dr. Nikhil, is he in the room? Okay, so today is his clinic day. He's probably in the clinic, may not be able to join us until a little bit later, but we'll be able to play his recording and then hopefully he'll join us for question and answer. So actually, while we're putting up the recording, I don't know if Dr. Oche, this is a good time for you to answer the question that was posted in the chat earlier. I can read it out and then you can quickly take that while we are setting up Dr. Bakta's recording. Dr. Oche, are you there? No, he's not. Okay, let me see. Okay, Dr. Oche is not there for now. Hopefully we'll get him back on the call and then we can take that question. So in the meantime, I'm just going to ask admin to please go ahead with Dr. Bakta's recording and then hopefully he'll be able to join us for question and answer before we are done with the session. Thank you very much. There's no sound, admin. Can anybody hear the presentation? I can't hear. Perhaps I'm the only one. Okay, so while we're just dealing with that technical difficulty, please unmute Dr. Oche so that he can take the question that we wanted to ask him because we don't have sound yet. So admin, please work on that sound. And please unmute our speaker, Dr. Nwoko. Doctor, try unmuting yourself actually, or make him a co-host. Make him a co-host so that he can unmute himself and take the question while we're dealing with the sound. Dr. Oche, can you try unmuting yourself now, please?
Oh, yes. So what was the question? I couldn't see it on the chat.
Okay, let me just read it out to you. So it was the question was this. Let me read it out. So 1 second, I need to scroll back up to find it. She essentially wanted to know, okay, let me read it out. Thank you very much for the wonderful presentation. And she said her network has been off and on, but she did hear you say that there's some symptoms that nurses regard as symptoms of typhoid fever and malaria. And while they are, they consider them to be typhoid fever and malaria rather than symptoms of cancer. And she wants to know, how do you differentiate the symptoms and how can you reach out to the grassroots for this need? So that's what she wanted to know.
Okay, thank you so much. In my own language, in Igbo language, anybody who has fever, whether it's due to any other infection or malaria or typhoid or fever from anything, in fact, or even headache, if they ask the person, what is wrong with you? They will say, I have IBA. So IBA is fever. So that means IBA is just the general language for any form of malaria or illness. So, and that's those days, once they say you have IBA, they will say, go to the person that gives the drug for IBA. So that means people generally assume that this sickness is IBA until there is some other person who says, no, this kind of IBA cannot be cured by this kind of medicine. You have to go to this other person that gives this medicine for this kind of IBA. So I'm just trying to use those local terms to explain what I meant. So sometimes, because a child will not communicate, if the child is unwell, the next thing is to cry. And even if it's fever, and then the fever subsides, the child will start playing again until another bout of that fever comes. So they hardly are able to complain, to describe what is happening to them. So the tendency for anybody to, first of all, go to a chemist shop or go to a community pharmacy or go to a private healthcare center is higher than going to a facility where such diagnosis of cancer can be made. So the point we're trying to make here is that people who are conscious of different kind of ailments or may think that this may not just be malaria, will have that inquisitive mentality of saying, doctor, please, can you help me check everything that you think I need to check about this child? I'll give you an example. September was Childhood Cancer Awareness Month, and there was a program we did in Akwa Ibom State in collaboration with Actionable Cancer Foundation. And when they were doing sensitization programs, awareness, they did screening in that community. So they were trying to just sample opinions of people to say, are you aware that children have cancer? And many of them who are saying, no, God forbid, how can God allow children to have that kind of thing? So there's a mentality that even children should not be allowed, as if it is one's making to allow or not to allow a child to have cancer. So some of the women say, no, God cannot allow children to have that kind of disease. So there's this perception that it can't even exist in children. So these are some of the myths that awareness programs need to demystify, need to deal with. For them, even if they are told that this may be a cancer, they shouldn't wave it off or say, God forbid. Of course, God can forbid and the blood just can cover. But then they should further step to confirm the diagnosis and that child initiated on treatment. So that's what we're trying to say, that the awareness program we're developing will have to sensitize the public to understand.
My name is Nikhil Bhatta, and I am a pediatric oncologist from.
So we have the awareness journal have been developed, which have been translated already into Yoruba, Igbo, and Hausa language, apart from Pidgin and English language. It describes different cancers, including leukemias, lymphomas, all the cancers that are common in our environment have been put in a jingle. And that jingle, we're also going to, maybe during World Cancer Day, unveil it and then begin to play across the country so that people understand different cancers and how some of the symptoms and how they present, so that when people see such things, they shouldn't just assume it's malaria. They need to go further for further tests, and things like that. And then, like I also said in a different program last week, that we also need to create awareness among health workers. Because even when a child has an ABA or whatever anybody want to describe it as, they go to a health facility. Health workers need to also be made to be aware of some of the early signs and symptoms of cancer that they don't need to keep in their private facilities. They need to take further steps to ensure that this diagnosis is confirmed promptly and treatment initiated as soon as possible. I don't know if that answers the question.
Thank you very much, Dr. Oji. I think that's answered the question quite comprehensively. You know, one of the things that I always talk about is that many times, especially with pediatric cancer, it is the health system that fails. We always talk about delayed presentation, but the real problem is delayed referral. And I explain to people all the time that an adult who has a headache, can carry on working and doing everything that they have. But if their child has a headache, they can't get anything done. So even the most disenfranchised parents on the average will take their sick child to who they consider to be a healthcare professional. What tends to happen, though, is that healthcare professional doesn't know the right thing to do, doesn't know the right place to refer to, and tends to misdiagnose or delay the diagnosis. And so it is often the healthcare system that causes the delays, not the parent. The parent presents to somebody who she thinks is a healthcare professional. It then is for the healthcare professional to appropriately detect what is going on, appropriately refer, and then for an appropriate diagnosis to be made. But thank you very much for taking that. We're going to take Dr. Bhatta's presentation now. And then hopefully after that, we will have just a few more minutes to take any final questions before we wrap up the session. Thank you so much, everyone, for joining us today.
Hello, my name is Nikhil Bhatta, and I am a pediatric oncologist from St. Jude Children's Research Hospital. I want to thank the Dorcas Foundation, and specifically Korede Adedayo and Seye for the opportunity to present and talk a little bit about what we do at St. Jude Global and how we're approaching many of the challenges that you've already heard about. Now, many of you have probably heard about what we do at St. Jude Global, and you may even be participating in some of the programs that we offer. But I'm hoping that by the end of this talk, you'll at least see how all of the different pieces that many of you may only see one component of really integrate together to address the comprehensive challenges facing children with cancer globally today. I have no disclosures to report. So briefly, as by way of agenda, I'm going to very quickly go through the introduction and framing of the problem, dive into this concept of a value chain and really borrowing from language of actually the business community, the Global Alliance as a tool, how we're building the workforce, and then ultimately end. And I'll be happy to take questions and answers at the end. So in terms of the problem, this does not bear repeating. Many of us know that in the United States, Europe, Australia, Japan, New Zealand, and elsewhere, survival for childhood cancer is greater than 80%, and honestly, greater than 85% in some of those settings for 5-year survival. However, close to 400,000 children develop cancer worldwide, and we expect that half of them never get diagnosed in the first place. And by far, the majority of these children, 90%, live in countries with limited resources. So when we look at the global survival, incorporating those children who are born and are developing cancer in these resource-limited settings as well, it is a sobering statistic that 20% of children with cancer will survive their disease. That 80-20 split is one of the largest paradoxes in all of global health. And we say that because ultimately, there are sustainable and cost-effective models that are possible in order to address the burden on children, a gap in childhood cancer survival. And we have to also remember that similar disparities occur for other catastrophic blood disorders, such as sickle cell, thalassemias, and others. And so, when we started this journey about 7 years ago, one of the biggest challenges was that we had no idea what global survival actually looked like. And even to this day, we still don't have a very good picture of what true global survival looks like. The best that we're able to achieve was by modeled data. And this represents the first attempt to model global childhood cancer survival. And based on that, based on data from Concord, from IHME, Global Burden of Disease, from IARC, pulling all of those data in from registries that we had, where we had data available, and utilizing surrogate measures, we estimated that about 37% of children who were diagnosed with cancer survived 5 years. However, when we account for those children that were never diagnosed in the first place, that almost all of these data upon which these models were built are now over 10 years old. And that is a major problem within the global health community. And so as a result, we must advocate for continued registration of children, not necessarily just models. And as a result, we must make sure that we invest in these data surveillance mechanisms. Otherwise, we have no idea of how good of a job that we're doing, no matter what I may say for the next 15 minutes. So based and confronted with this challenge that I just highlighted, how do we begin? How did St. Jude Global really approach the major task of addressing these huge global gaps? So first and foremost, we recognize and put the child at the center of everything. Recognizing that child lives in the hospital, lives in a country, in a region, and is a member of our global community. And St. Jude Global needs to work across all of these layers to ensure that we reach every child everywhere. And so beyond just trying to make that a slogan, what does that mean? How do we work? What is the core sentiment of what it is that guides our approach? And it is really that we are seeking to empower our partners. And that sounds very, very simplistic, but it is truly core to everything that we do as an organization. For those of you that have worked with us, you know that we spend a lot of time doing strategic planning, building tools, and doing a lot of design thinking. What means, if you've ever been in one of our workshops, it's a lot of sticky notes, a lot of using Sharpies, and a lot of thinking together in groups in order to reach solutions that are not defined by St. Jude, but are defined by those who live locally and are really then implemented by those same individuals. And so we work across all of the different components of the health system, but also we address all of the major facets from patient care, education, research, as well as advocacy and resource mobilization, thanks to our colleagues at ALSAC. And we work with all stakeholders, whether they are local leaders, community groups, government, hospital administrators, WHO, NGOs, and of course, other international academia and international NGOs that may be also working in the region as well. Only by working together can we really address this global need. And so when we think about it at St. Jude Global is that this is as a value chain, meaning that if we put the child first, what does that mean? That means that that child has to be found, referred into a hospital, get diagnosed with the correct diagnosis. Then that diagnosis means that we have to find the best possible treatment available based on the resources that are locally can be used. And then make sure that we are equipping those hospitals with medicines and technologies based on the local contextual availability that is there, because we know that there's stockouts and other issues. And then ultimately ensure that in the hospital where the child is receiving and treatments, that the best quality of care is being delivered at the bedside. And so how do we work across this value chain? And so I'll briefly talk about different facets upon which we have implemented. So at the case finding and referral, one good example of where we've been working is at the health systems and health policy level. So many of you are familiar with the Global Initiative for Childhood Cancer. This is a WHO initiative specifically for childhood cancers that was initiated by the World Health Organization together with St. Jude. And it was launched in 2018 at the UN General Assembly with the goal that by 2030 we will double survival to 60% globally, and that children with cancer that all children with cancer will have reduced suffering. Ultimately, we estimate that this will result in 1 million more children saved. And together with SIOP and CCI and many other partners, this has become a massive success. First and foremost, we launched the Cure-All package, the first technical package tailored to governments to explain and address how should they be addressing the childhood cancer burden in their own contexts. And together with many partners around the world, we have seen an explosion of interest, going from 0 countries really focusing or addressing childhood cancers to now over 76, I think like over 78 or 79, these data are a little bit old, countries really now working to address the childhood cancer burden in their countries through a variety of different mechanisms, either through memorandums of understanding with the Ministry of Health and WHO, or doing activities or to having actual dialogues with their constituencies. And this is a major impact and progress because we are now starting to see childhood cancer introduced into health benefit packages and also children advocacy groups being able to come into the halls of power and be able to influence government in order to make resources available or at least get red tape out of the way. And so in addition to the WHO, we've also partnered with other UN organizations along this journey. For example, IARC, International Agency for Research in Cancer, to help support childhood cancer registries, IAEA with the Rays of Hope for Children, PAHO for a lot of the work that's happening together with them at the GICC, as well as our global platform, as I'll talk about in a minute, and the same with UNICEF with Drug Access Platform, the platform for drug access. But we also know that we can't just only focus on getting children into hospitals. We have to make sure those hospitals function. And one of the most intractable challenges has been getting the correct diagnosis. We know that there is a global diagnostics gap. We've seen the survival issues, and we know that many children go undiagnosed. But when we look at the data, how much availability of access is there? We've done assessments in over 250 hospitals around the world, ranging from low, lower, middle, and upper income countries. And you can see that when we look at the number of institutions, this is just for leukemia, the number of institutions that have morphology, most institutions have access to morphology. Fewer have access to flow cytometry within 7 days. And when we start getting into the low and lower middle income countries, you can see access to FISH, cytogenomics, and PCR are incredibly restricted. But even so, at upper middle and even in high income countries, these are labs that are often sent out and they take weeks to come back. And of course, there's no telling how many they actually have, how many panels, how many actual assays are available to give a comprehensive diagnosis. And we know that the challenge to approaching the diagnosis of leukemia is quite difficult. And this is just one example. The same thing could be said for solid tumors, brain tumors, etc. We start with the morphology. You see round blue cells. Could this be ALL? Could this be AML? Could it be a lymphoma? Could it even be a solid tumor subtype? And so what we do at St. Jude is we have access to we have access to flow cytometry. Some others in the world use immunohistochemistry if they don't have access to flow, at least from the old days. And then we use a variety of cytogenetics and FISH, and then more and more molecular diagnostics. Of course, the dirty secret is that as we continue to add on all of these tests, and that is true, they add on, they become more and more expensive. And over the recent years, we've seen a proliferation of the next generation sequencing tools, but mostly in the research environment. Over the last decade, there's been a ton of papers that have come out about Illumina research classifiers. Most of these classifiers, of course, are based on gene expression pattern or machine learning. They're not truly direct observation. And as a result, there's a potential risk that they are incorrect, and then one that we're often not willing to take. They're also not implemented across multiple sites. Most of these are individually implemented at their institutions. And then the cost per platform is huge, still over $1,000. In one of the testing platforms that we're using on Illumina, we saw the cost per test was about $1,700 for leukemia. And they're very computationally complex, requiring access to high-performance computing clusters or cloud-based computing clusters. So the question is, when will these ever be practically relevant? And so we've been working with colleagues from UNC and from Princess Maxima and others to really think about how can we take cost-effective tools such as Oxford Nanopore sequencing and make them available. And we've had multiple publications, NIH studies. Our colleagues from Princess Maxima have had publications that have made quite the splash over the last several years, really showing that this is not just a theory, but actually practically implemented. And so they're actually using these tools at Princess Maxima today. And so what does that mean practically? So that means that instead of using all of these individual tests that we use on a regular basis in order to come up with all of the different components that go into risk classification and ultimately cost a lot of money and are not accessible in many settings, we're working to think about, can there be a one singular assay? And this is not a hypothetical. This is actually really happening today. And we're really excited over the next few months to share more with you on this area. But this could be done, and we are really thinking, and we really believe that this could make changes to how we implement globally. And to do that and to support that work, we really want to make sure that that sequencing is happening in country, in context, such that DNA or RNA is extracted and sequenced locally. And then we can support with cloud environment computing analyses that really allow for any individual to be able to get answers to what they're actually classifying, and then return those results for clinical pathologists, but also utilize that to create a database for which we can actually expand our knowledge, understand how variations in race and ethnicity impact what we're doing, and ultimately result in more children being saved. And of course, like I said, not just having the diagnosis, but we also need to understand how resources are being adapted into context. And for that, we use ARIA Guide. So for many in the world, there's always a goal and an aspiration to have a protocol. But for many, we also know that there's just either a paper or a letter from in terms of from a colleague in another country saying, here's what you should do. Here's a publication. Here's a letter of with some drugs in it, and they suggest what to do. And that's the reality, is that most children are treated based on these kind of basic treatment plans, while everyone aspires to and really wants to implement clinical trial protocols. But ultimately, for multiple reasons, we've never really had guidelines. And by the guidelines, I mean the standard of care, which provide contextually appropriate, comprehensive cancer management plans. And what does that mean? It means that you have everything from the diagnosis, the risk stratification, the drugs, but also things such as what happens when there's a stockout, what happens when you complete therapy and you have survivorship components, what happens if you have drug toxicities, how all of those things and side effects and supportive care, all of those go into a guideline. Those have not necessarily existed, including things like the PSYOP ATRs, which were really publications back into that treatment plan side, not guidelines that use a comprehensive methodology. And that's what ARIA seeks to deliver. And we don't want to do this at a hospital or a country level. Our theory is that if we work together as a global community, much because as childhood cancer experts, we generally like each other, we're pretty nice people. If we can work together to develop these guidelines as a global effort, we can actually reduce a lot of time, and then we can actually spend time adopting these. And ultimately, that means that we can actually study this in context instead of spending all of our time writing that. And what that means is we reduce all of the redundancy by working together, and we actually allow each of our hospitals, as part of the standard of care, to become natural innovation labs that ultimately improve outcomes over time. And so how does ARIA work? Well, first of all, we do disease-based guidelines as well as non-disease-based guidelines on supportive care, palliative care, and survivorship, and growing other topics. And so at the core of ARIA is community engagement. We work with multiple national professional societies, collaborative groups, and others in order to receive nominations from their networks into ARIA Guides, ARIA Guides representative panels that ultimately provide the input for how we should be able to review and ultimately give contextual evaluation and input into any guideline that we develop. Each of the guidelines have multiple disciplinary input. They have input from all WHO regions and all World Bank income levels. At the core, we have a central coordination system as a team that is based at St. Jude and supported by our team at St. Jude and funded through St. Jude. And that is really the engine that drives all of this work. And then we have a methodology of adaptation, really building on evidence where it exists, but recognizing that most evidence is from high-income countries. There's consensus with not just content experts, the people who write clinical trials, but context experts, people who live in real world environments and can provide input into whether something is reasonable or feasible. And of course, we make sure that we have patients and persons with lived experience engagement in all of these activities. And then we pull all of that, and we actually have developed an ARIA Guide platform, which allows us to disseminate these guidelines. And at the center of that, it's not just about putting this online as a PDF, but really figuring out how we can develop tools using user-centered design methodologies to make sure that they're available. And to really make sure all of this happens in a unified, standardized, and trustworthy approach, we've developed governance structures with SIOP, CCI, PROS, IPSO, and St. Jude Global, as well as SOPs that are transparent and online. And we've put all of this on ariaguide.org. Today, there's over 120 guidelines and clinical recommendations that are planned. You can see here the progress of all of these, with 25 already available on the website today, 58 guidelines in progress, and we have nearly 700 global reviewers engaged from over 90 countries in this process. This represents the global community. And they are already available, freely available today at ARIA Guide, the ARIA Guide portal. You are free if you're a healthcare provider to log in and test this. But then, of course, we know that we can't just have the guidelines. We need to have access to the medications as well as other tools. And so for that, St. Jude and WHO partnered with a $200 million investment from St. Jude over the next several years. We will provide access to nearly 50 countries and 120,000 children to free life-saving medications. And to do this, we're not just building a platform to deliver medicines, we're delivering this platform as a health system strengthening tool, collaborating with local leaders and governments in order to strengthen the health systems, not necessarily just alleviate the stress to them. And so we've, as I said, there's a $120 million commitment, and the first 6 countries are receiving drugs today, as you can see there in red, and the second cohort is currently working hard to do that. In the Africa region, you can see Senegal and Ghana currently in the process, and Zambia has now been receiving medications for nearly almost a year at this point. And then finally, all of that would be moot unless we make sure that we improve the systems inside the hospital itself to improve the quality of care. And the way that we do that is through something we call our SJ Cares implementation framework, recognizing that at the center of everything has to be a cyclical process. There's no end. It just keeps having to improve. And we do that through local adaptation processes. We adapt treatment. We monitor outcomes on those treatment. We assess the quality of the services that are being delivered. We ultimately figure out how to intervene and improve on those services, and then we continue to adapt and cyclically improve. And I've already talked about ARIA, but we have a global registry network, which allows us to monitor outcomes, profile, and then a variety of global packages, which are quality improvement and implementation practices that allow us to actually improve the systems within the hospitals themselves. And all of this exists within the health system and the policies, which really allows us to think about how this SJ Care system works. And I mentioned the registry. We have a core hospital-based cancer registry network that we've developed. We also have sibling registries to address infectious diseases through VivaReg and critical care through POCIReg. And we're right now building out additional forms based on ARIA that would allow for hospitals to even take a deeper dive into disease-specific interests that they have. And you can see here, we have constantly growing, and that's actually an older figure from March of this year, but we have over 27,000 patients now in the registry, over 200 data use agreements signed, 400 individuals trained, and it's available in 2 platforms, a REDCap as well as a cloud-based tool. And those registries provide an opportunity for research. Hospital-based cancer registries allow us to create those natural history models to really assess how good of a job are we doing at the hospital, and everyone should be doing that. But then on top of that, we have our global packages, which allow us to do quality improvement activities or implement new programs or implementation studies like DIVIA. And then, of course, in the future, we hope to add on novel therapeutics research. Of course, that'll happen to very few children and benefit very few children at first, but the goal is that in those we can learn and then expand those backwards up and through ARIA and the Drug Access Platform and other mechanisms in order to show that all children benefit. And of course, at the last, we can't do any of this without having educational activities. And so we have at St. Jude Global, we've created clinical training programs, training courses, with hybrid training as well. And then, of course, distance learning through Cure for Kids, which is a platform many of you are familiar with. And then finally, just to end, all of this is being implemented through a St. Jude Global Alliance. This started in 2018. As you can see here, it's grown exponentially over the years to 2024. And this is actually almost a year old, but you can see today that we have over 385 institutions that are part of the Global Alliance in over 80 countries around the world, and another 80 foundations that are part of the program as well, spanning the globe and continuing to grow, such that we think that today, members of the Global Alliance reach at least a third of children who are diagnosed with childhood cancer at this time. And so with that, I just want to end by highlighting that I just showed you the value chain. We work across all of these activities of program building, research, advocacy, and education. We have our educational programs like the Global Academy, as well as our Global Scholars Program, of whom many are from the Africa region. We work across registry, tools that assess context, such as policies, or our profile tool. We have ARIA Guide. We apply research methodologies and training in that. We have a bunch of tools that help to support health teams and health systems. Then, of course, there's all of the quality improvement tools that some of you may be participating in, advocacy and resource mobilization to support foundations, and again, empowering all layers through at the highest level, really engaging with Cure-All, with the WHO and others. And then, of course, novel and innovative activities such as DIVIA, which for diagnostics, and then the global platform in order to provide access to children, for medicines for children. And we work with other partners such as IAEA, IARC, and others, UNICEF and others. And with that, thank you so much for this opportunity to present. I'll be happy to take questions at the end.
Thank you very much. That was a presentation from Dr. Bakta, who is, working with many, many countries, and especially with us in Nigeria as part of the St. Jude Global Alliance. And before we end the session, when I will call Prede Akindele, CEO of the Dorcas Cancer Foundation, to wrap up, I just wanted to say that, I was thinking about it, and one of the things that I have to do with everything we do is ask ourselves, what's the point of this? So how is this going to improve survival? How is this going to help another child survive? What is the point of this meeting? And I remember, I sat with the team, I said, what is the point of this meeting? What are we trying to do? What is the point? It's not just about, ticking a box to say we had a presentation on London Global Cancer Week, but what are we trying to do? We want to show that impact comes from real people and very ordinary people at that. It doesn't. The other day, a young lady was saying to me, she's a breast cancer survivor, and she was saying she would like to start advocacy work in breast cancer. She doesn't know where to begin. She's been on a couple of radio shows to talk about breast cancer and talk to a couple of people. And I said, what do you mean you don't know where to begin? You started already. And that really is it. As Dr. Akisha said when he spoke, 10 years ago, we were not in the room, we were on the corridors. And when you would have conversations with policymakers and even healthcare professionals, they'll tell you, oh, the children have cancer. And there's a shift of attention that has happened that everybody can see is palpable. But that happened because people continued to talk, ordinary people, ordinary survivors, ordinary patients, ordinary, healthcare professionals. And someone might argue that they're not ordinary, but when I say ordinary, what I mean is everyday people like you and I, and it really just is about getting involved and wading into the fray and starting the conversations. It is, and one of the things that I've learned to do is I always say to know, I will knock on the door until my knuckles peel. So people need to work harder at being, resilient, at not giving up. There were times when we all wanted to give up. There's been times when I want to give up. There will be other times when I want to give up. But the truth is that, Corridor will always say to me, if you give up now, how does that help? Like, it's not working, so you give up, and then that makes things better. How? So the point being this, in any other country that has similar circumstances, you have resource constraints, you have a shortage of healthcare professionals, you have infrastructural deficits, you have healthcare system gaps. The first thing to note is that this isn't unique. Even in the seemingly high income countries, there are real problems going on in every single place. So first of all, it's not special. You're not special because you have problems. You're not special because you have gaps. The second thing is that it's going to require people like you and I to fix it. We don't wait for government. We don't wait for policy. We don't wait for healthcare professionals. Government is me. Policy is us, you and I that will change it. We have to be the ones to decide to speak up about it. And so how do you begin? You begin by starting. That's how you begin. You begin by deciding to say, I'm going to get involved and I'm going to try to help. And then you also, what I would then say is on a practical level, you have to be realistic and you have to be scientific. So one of the things we did at the beginning of Dorcas Foundation was fund treatment, but we had no survivors because you're funding treatment for children who have come in stage 4. You're funding treatment in institutions where there's no pediatric oncologist who knows how to treat cancer. That's not going to help anybody. So you do have to sit down and really understand what the problems are for you to be able to come up with innovative, realistic, context-relevant solutions to those problems. And just before I conclude, I want to see if there's any questions. Dr. Nikhil Bhatta has joined us. Welcome, Dr. Bhatta. Thank you very much. We know today is a busy clinic day for you. We're very grateful that you're able to join. I would invite you to, say one or two things to wrap up your presentation. We'll take any questions and then we'll wrap up the session. Thank you very much.
I'll just say I'm sorry for being delayed. The United States decided to do daylight savings time, and of course that means that it plays havoc with everybody's attempt to plan in advance. So many apologies for not being here at that point, but happy to answer or address any questions. And really, I appreciate the opportunity to be here for this very important session.
I actually don't think there's any questions. I don't see any questions in the chat. I think that if anyone is interested in some of the information we've shared today, if you'd like to join the St. Jude Global Alliance, if you'd like to participate in some of the programs that have been discussed, please go ahead and reach out. We will be very happy to connect you. And if there's any information that we've shared that you want more detail about, WHO, DICC, St. Jude Global Alliance, anything like that, please go ahead and reach out to us. Thank you very much, everyone, for joining and for listening. So, Corey, I'm going to just invite you to finish the session and send everybody on their way.
Thank you everyone for joining. So I'd like to just say a very big thank you to everyone. And I'm going to start by saying a big thank you to Dr. Uche. Thank you so much, Dr. Uche, for always been there. You've been there for us from the beginning. I remember when the whole journey started, we called on you and you listened to us, time of listening to our play about pediatric cancer in Nigeria and all the amazing work that you just presented, that you've done in the process of here. Thank you very much for your commitment to pediatric cancer in Nigeria. Thank you very much for your commitment, even to us at the Dorcas Cancer Foundation. I mean, we really appreciate your support. When we send you an email, you answer our WhatsApp, our calls, you've always been there. Thank you for being there for the children. I mean, that's the core point of our work. And thank you so much for how you've been able to work with us to move the pediatric cancer forward in Nigeria. Like I always say, we're on a journey. And I'm glad that we are on this journey together with you to create a future for every pediatric cancer in Nigeria. I'd like to say a very big thank you to all our speakers also. Thank you so much, Nikhil, Dr. Nikhil Bhatta, for being part of this session. I mean, even joining despite a very busy clinic day. Thank you so much for the video. It was so informative and for also joining. I'd like to say a very big thank you to Dr. Adeshaya Akinshete. Thank you so much, Dr. Akinshete, Thank you also for being there for Pediatric Oncology patient and for Dorcas Cancer Foundation. We call you, you always answer us. It's so amazing to us. Thank you, sir. And Paulette, Ibikwe, thank you so much, Paulette, for your commitment also from your days in charge to your next assignment now. You've always been there for us. I'd like to say a big thank you to also Team Dorcas for doing this. All this is being put together by an amazing team at the Dorcas Cancer Foundation, led by the Executive Director, Dr. Adedayo Joseph. Thank you, team, for being there for us. So please, to all our participants, thank you very much for taking your time to be part of this session. We really appreciate the time spent, and we hope you get one or two informations that is needed to work with us. Please just keep tab to us on your emails. We're going to be sending you emails about our programs in 2026, and feel free to reach out to us. Just like Dr. Joseph has said, we can connect you to any information that you need regarding pediatric oncology in Nigeria or all the partners that we work with. On behalf of the team, I'd like to say thank you and have a wonderful day ahead. Thank you.